I hope that people will hang on to hope. There are resources. I have to acknowledge that sometimes it's hard to find them. Keep going, keep trying. And oftentimes people see a lapse as a failure, and it's just part of the journey. Yeah. So to keep hope, as long as you're still here, take that next step. And that there are people and places out there to support you.
Substance use disorder touches all our lives, and often we feel hopeless or frustrated in our pursuit to understand how and why it happens.
Welcome to APC Recovery Cafe, where we discuss the topics and trends around substance use, provide education and resources, offer recovery support, and also discuss prevention tactics, all through the stories of the people who have been there.
We invite you to grab your favorite coffee or tea and join us for a variety of guests that will bring understanding, information, connection, and hope.
Together, we can break the stigma and pave a brighter future for each other.
Hi, folks. Welcome back into this episode of APC Recovery Cafe. I'm Art Wimberly. I'm a person in long-term recovery and a volunteer at the Addiction Prevention Coalition. And today in the studio, I'm with my co-host, Carrie Wimberly, the Executive Director of APC. Good morning, Carrie.
Good morning. What's up?
Oh, not much. It's been a while since I've seen you.
I know.
Yeah. 20 minutes? Yeah. But excited to be back in the studio and love for you to introduce our guest today.
Yes, very excited. We have Bronwyn McInturff. Bronwyn, I probably one of the very first people I met when I joined APC, has been a friend of the organization before I arrived, also a partner through UAB Addiction Recovery, and now a board member of APC. Thank you for joining us today and your service and your partnership with APC. We're so excited about this conversation.
Thank you. It's my pleasure. Truly has been.
Okay, well, so we always start out by talking about the beverage of choice, since this is the Recovery Cafe.
Got it.
And people won't recognize the label. We actually have a coffee shop down in the bottom of our building, which they produce some nice coffee. But you requested black coffee, which I think maybe we've had one other black
I don't
coffee.
think anybody just wanted black coffee.
Okay,
yeah.
so
I mean, usually I have to run all over town to get this like extravagant concoction.
Yes, because I tell people, okay, what is it? Because whatever it is, we'll get it for you. And then Art actually gets it. I don't actually go. He runs around like crazy and gets it.
Like just black coffee.
So, what's your history with black coffee, and do you have an aversion to all the coffee? I was thinking about trying to, all the adjectives are things you do when you order from Starbucks, but I'm so not Starbucks savvy, the, non-fat decaf
with 2 shots.
Yes, with 2 pumps of whatever and a stevia.
I still think all that came out of the show Frasier.
Oh,
from
please.
25 years ago.
My mom is a great Starbucks orderer. She does the...
What's her order?
I think it's a mocha, skim milk, 1 pump, light foam.
And I swear I believe the barista, I swear, is going just dumping stuff in there.
I know, but is there a class? I mean, how do you just have to spend time there and listen to all or you have to have a relationship with a barista that educate, because I never have gotten the lingo. But
maybe an apprenticeship. I don't know. But I have always had coffee in the morning, only in the morning. Don't drink it at night. Yeah. And it is just this beautiful ritual for me, a way to start my day. From the moment I get up, I turn on the coffee pot and I smell the aroma. And now... my kids are older, so I'm not having to run them to school. So I walk my dog, come back, have a cup of coffee, do, a little word puzzle or something, and have some quiet time, and it's beautiful.
Nice.
Now, the black coffee started as age crept along, and I thought probably need to cut back on some sugar and other things. Now I just cannot drink it with the sugar in there. Every now and then I'll have just a latte, just some
Yeah.
espresso and milk.
Yeah.
But I like it.
Like it black.
Plain and
Good for you.
and just the smell of it, and
Yeah.
it's lovely.
Yep.
Plus, it makes it easy for people to take my order.
Thank you very much. Yeah.
Yeah,
Didn't have to come early today.
that's right.
Well, let's go into background. We established earlier this morning. Actually, I've heard the name McInturff connected to mental health in Birmingham for a long time. Turns out that was your mother
Yes.
that I was familiar with. So you kind of come by it naturally, right? So talk to us about how you got into the field.
Sure.
And some of the educational background.
Absolutely. And it's funny because I remember my mom, one of her first jobs was it was not called Bradford back then, but it was on that campus. I think it was Brookwood Lodge
Yeah.
back
Okay.
in the day.
Yep.
And I would go out with her sometimes when she had to do like a late night group, and I'd go sit, in
Was
an
this out
empty
at Warrior?
office. Yeah.
Yeah. Okay.
And
Wow.
she would go out there, and I'd go into an empty office. And she also worked for a brief amount of time at Alethea House, which back
Okay.
then was one of those big old houses
Yep.
on, I think, Nyazuma.
Yeah.
Yep.
So early introduction to mental health, to seeing my mom work with and enjoy working with those that had substance use disorders, and she loved it. She was good at it. So when I was in college, I majored in psychology, and I knew I wanted to do work in the mental health field. I took a few years off after college. I thought I would get my PhD, and to be able to do that, at least at that time, you had to publish something. You had to show that you had some work experience and do some research with another practitioner, get published with that practitioner. So I worked at UAB in neuropsychology. I did not like research, and I did enjoy it at the time. I just thought, this is not for me. There was another person in the office who was going back to grad school, and she was going to get her master's in social work, and she told me about it. I read about it. I read about the program, and I loved it. Just the things for me: direct practice, compassionate, non-judgmental care, real focus on advocacy for communities and people that often people don't hear their voice, don't want to hear their voice.
Yep.
So that's what drew me to social work. And my first field placement, so in social work, you do 2 years. The first half of the year, you're doing academic work only. Second half of the year, you're working 32 hours a week, like a job, under someone's supervision, and then you do your academic part 1 day a week. So my first experience was at the Tuscaloosa VA, and I got to see different programs that were there, and one of them was it was called PACSAC, Primary Care Substance Abuse Clinic. They all called it PACSAC, and it was just residential care for those with substance use disorders. And it
was among the veteran population, I guess, because
it
of
was,
the VA.
yes, exactly. I loved it. I loved everything about it. I discovered that was part of my passion. I loved getting to do assessments, individual and especially group. But I felt kind of awkward because I am not a person in long-term recovery. They employed a lot of folks in long-term recovery there, although there was a diversity, a mix. I remember before leaving that internship, I sat down with one of the people that worked there in long-term recovery, and I asked him, I said, is this something I could do? Is it okay for me as a person not in long-term recovery to do this?
Yeah.
And he was so warm. He said, yes. He said, we need you.
Yes.
We need people that want to work with people trying to get recovery. He said, we don't need just one set of people or voices.
Yes.
Again,
he said,
that diversity of experience
and he
background.
he gave me such a, yes, we need you, that it was very encouraging to me and sort of set me on a good road. So I graduated, and I asked my mom, I said, Mom, what should my first job be, as I'm building my career? She's a therapist in private practice. And she said, hands down, you need to do addiction recovery work. She said, it will touch every aspect of what you do. And she said, if you don't know something about that, you're going to be in trouble. You need to know what you're doing.
Yeah.
And she said, plus working with people in that area, you're also going to be working with folks who've experienced trauma or anxiety or depression, or they may have
the whole
family
gamut,
issues going on. And I always joke because we were talking earlier about youth, and so I laugh at myself that I asked my mom, what should my first job be, as if the world would all be at my door.
Yes.
And so my first job after grad school was telephone operator, because nobody would hire me with no experience. So I worked doing that for a summer. It was a corporation. It was that I'd worked for before during summers in grad school. But then I immediately, after a few months, got a job in substance use treatment. My plan was to do it for 5 years and then go into private practice. 23 years later.
Oh my gosh.
So
was UAB the job?
UAB was not the first. I worked at Birmingham Healthcare for the Homeless, and they had a grant through National Institute of Drug Abuse. They called it their NIDA program.
Yes.
And they did treatment, outpatient treatment for homeless population. And it was a research study around how housing impacted the ability to complete treatment and maintain recovery over time.
Yes.
But the treatment aspect of it, which I was involved in, was just day treatment. So that was my first job. Then I went to UAB, and I was there 22 years.
Wow.
Yeah. And, I often think about, people ask me, why didn't you leave? And I was never bored. I was always interested. I absolutely loved the patients and the work, and I only loved it more the more I got to know about it. As you said, Art, you at first just sort of stumble around. You don't know what you don't know. Then you start working, and then you really find out what you don't know. Yes. And that becomes exciting, incredible. But one of the things I loved most about it, I don't know that I've ever experienced the kind of change in people that happens with recovery.
Yeah.
And getting to witness that and just play a small role in it was humbling and beautiful. When you see somebody who, with recovery, is even better than they were pre-disease.
More of who they were intended to be in the first place.
Yes.
Right, yeah.
It's
not just coming back to zero. It's, okay, now you've got the potential to be who you were created to be. Yeah.
Exactly.
Yeah.
Well, and like I said, you were one of the first names I heard when I, entered APC. But, working with people in long-term recovery, I cannot tell you the number of people and it's people that have been sober a while, but when they got sober at UAB addiction when there was inpatient.
Yes.
And I was just telling you, like, the stories that they talk about, like, many of those people had gone to treatment in different places and then ended up there thinking it wasn't going to be anything. But the theme that I hear from people that got sober there and had an incredible experience is that the people that were working with them really saw them and cared about them. Like, it was an eye-opening. I don't know what you guys did, but it was, and they mentioned you by name many, many times, but that they felt like a person again and that they were worthy of getting better,
Well, that makes me want to cry. That's so beautiful. If I could hold that space for one person, then I've done it. Yes, I think working at UAB over the decades I was there, that is the direction we went into more and more. What helps somebody who is in the midst of a substance use disorder. And I think individualized care, compassionate care, and most importantly, or at least importantly, is non-judgmental care.
Yeah.
Because the people who are in the midst of a substance use disorder are ashamed. And, nobody's going to shame them more than they shame themselves.
Yes.
Yep.
And letting them know that we're not going to reflect that back to you is a very powerful experience for them. In the old days, the old days, part of treatment was confrontation. Part of treatment was denial breaking. And I'm so glad that research shows that really doesn't work.
Yeah.
And that everybody kind of as an industry moved away from that.
Yes.
Yeah, whatever role those two things play, it's usually not the very first thing that anybody needs. And the way it was being delivered was counterproductive to real recovery.
It really was.
For most people. Yeah. So talk a little bit about kind of the genesis of how things moved through your couple of decades there in terms of, you just mentioned one of the changes you've seen for the better. One of the things that was a disappointment in the community here was when UAB ended their inpatient. So talk a little bit about the need. I mean, we don't need to get political or anything else, but just talk a little bit about the gap that leaves and maybe where you see, is there anything being done about it in the community?
So we had a really unique program because sort of to understand why there's not more residential facilities, insurance does not reimburse that. So, and we won't talk about who, but insurance does not cover residential care. My observation only is that, substance use disorders are one where denial plays a part, where sometimes somebody does not really seek help until it has reached a crisis point.
Right.
When somebody just starts having trouble, they write it off, and then they try to take care of things on their own.
Or they've got a family system that's kind of enabling and caring.
Exactly. So when things reach a crisis point, outpatient treatment often isn't an intense enough level of care. So residential is a lot of times where people need to start once they recognize this is an issue for me. Insurance doesn't cover that level of care. What we did at UAB was it was a partial hospital program that we could bill insurance for, and then the patient paid out of pocket for their stay in the evening. And I think just volume-wise and reimbursement-wise, it was difficult to maintain financially. And we had a lot of discussions about reimbursement rates from third parties that just not willing to do it. And that, I think, pertains more to this state. I do know there's some other states where there's some reimbursement for that level of care, appreciation for that level of care, and how oftentimes people in the midst of a substance use disorder need at the beginning a safe environment, a structured environment, a supportive environment.
And a medically sound environment.
And where you can build up your skills and your confidence before you go face triggers in the real world. So there's really not a lot of programs like that in this state. And
so how has the industry, or how have you personally seen trying to compensate for that by adapting around that with different IOPs or outpatient programs, or how have we kind of put some pieces in place to try to serve where that's just not, we don't have a lot of good inpatient?
Well, we're lucky in this area that we have so many different and so many strong self-help communities, and they really help fill in. So when we work with someone who's coming to outpatient care, even if they meet criteria, we still want to make sure that they are supported throughout their day if they're only going to be with us for part of it, or when I was there. So we would engage families for support and help. We would engage friends. We directed patients to the self-help community, made schedules with them. And we also made sure that they had what we call it, sort of your 911 plan, where we wrote out all the different opportunities available to them on a 24-hour basis. UAB still has an inpatient detox.
Right.
That's a shorter-term medically monitored unit where people stay anywhere from 3 to 14 days, well, even up to 21, depending on their medical condition.
Yeah.
And so you get some of the aspects of a residential unit there in terms of, like you said, that
Just stabilizing physically,
somebody.
physiologically.
It's not the same, though,
Right.
as
Right.
treatment, as we all know. People who, the research shows that detox alone, typically about 90% of people return
Yep.
to having another episode after that.
Right.
Because it doesn't address all the psychosocial aspects of the disease. It's addressing the physical aspect. Yeah.
Yeah. Well, I know you and I have done work together and all the stigma summits. I would love for you to talk a little bit about the efforts that are in place to kind of break down, what we're talking about, the change into a more compassionate approach, and the challenge and what lies before us to try to educate, communicate, and encourage a change in thought and a change in language. And we'll post things and people will say, what is the big, so we're engaging people, on media, but talk a little bit about that. Cause I think when I think of, you've done a lot of webinars for us, about educating people about the importance of language and all that in breaking stigma and why that's important. So talk to us a little bit about that.
Yeah, it's a great topic, one that I love, as you know. So when I talk about stigma, I typically start with a quote, which was from 1994-1996 by Dr. Alan Leshner, who was the head of NIDA, National Institute of Drug Abuse at the time, who said, we have the science background now to address substance use disorders as a disease. He said, we have this. We know what to do. We know how to treat it. We have the research. He said, but stigma is the number one barrier to addressing this disease. And I always say, that was 1994, and I think it's still true today.
Yes.
That there is still a lot of stigma around this disease. I will say I've seen change, as I discussed earlier. Treatment practices and the treatment community has changed. At UAB, I was able to witness a lot of change in hospital practitioners, not everyone, but a lot, who came to me in my role as manager and being over both a treatment team and a consult team. Our consult team was a team of practitioners that would go see hospitalized patients for other reasons.
Right.
But they might have a substance use disorder. Yeah. So the primary care physicians came to us and said, will you help us with these patients? Our medicine doesn't address what's going on with them. And they showed a lot of interest in that and compassion. And so we were able to, over time, really make a dent, I think, in hospital culture. And a few people helped us in. But I still see day to day examples of stigmatizing language in the medical community. A lot of people are not even intentionally using it. But the thing about language, it's like a feedback loop. When we say and we use stigmatizing language, it influences us in conscious and unconscious ways, when people hear us use that language, it influences the way they see a patient. You know, there's a great research article about that from the Recovery Research Institute, that using the word substance abuser versus a person with a substance use disorder has a huge impact on the way that people rate the same person they're reading about on a piece of paper.
Yeah.
So just the person first language.
Yes.
This is a person who has a substance use disorder, instead of saying they're an abuser.
Right.
Yeah.
Because we have a lot of negative connotations as a society with abuser, and we don't necessarily realize, because people use that term all the time.
Yeah.
I see it in charts. I hear people say it in the hallway. Again, not having bad intentions, but it's impacting
Yes.
sort of the cultural viewpoint
Yeah,
as a whole.
which eventually has to affect policy.
It does.
Yes.
That type of thing. Just this week, Carrie and I were talking an article by, if I said the name, everybody here would know the person.
Yeah.
Unfortunately, they're a large celebrity media influencer, and the thrust of the whole article they wrote was about we're going way too far in this victim mentality with people with substance use. I'm like, hey, I don't.
And it was very
disagree that-
strong,
Right. I don't
derogatory
disagree that we
language.
probably overcorrect on victimhood in this country, but this is not useful
Helpful.
in this conversation about people who struggle with substance use disorder.
That's right. And our language does shape policy. I mean,
Yes.
you're absolutely right. And it influences what we're going to do as a treatment team. So if I say this person is an abuser, drug abuser,
Yeah.
the implication is they're doing something wrong, they're doing something bad, and as a hospital, we don't treat moral issues.
Right. Yeah.
If I say they're a person with a substance use disorder, now they have a condition. It's identified in a clinical manual, and there's a treatment plan for that.
Yeah.
So I've empowered a practitioner by just changing words. Now you do know what to do.
Right.
Versus substance abuser, kick them out.
Yeah.
We can't help them.
Yeah.
Versus the other, I know what to do.
Yeah.
And it empowers our practitioners, I
Yeah.
think. So I think that person was,
Yeah.
I don't see it as victimhood. I see it as just correctly identifying and having a roadmap of what to do.
Yeah.
But yeah, I think stigmatizing language and stigma are still out there.
Yeah.
And they're a huge challenge. But strides are being made. One thing I love about the Addiction Prevention Coalition is your social media campaign, because it addresses so many aspects of stigma and mental health and I think just positive
Yes.
health messages that
Yeah.
go out there.
Yeah, and I
It's
think
really nice.
we early when I first got to APC, as we were rebranding, we were going through that process, which is an interesting process. When you get somebody that's really good with branding, and they take you through all of those conversations, and you're having to, they're asking you all these questions which you thought you knew the answer to, but you're really having to make decisions about, okay, really, who are we and who do we want to be, and brand recognition or whatever. I mean, ultimately what we came up with was, hope. That's like, you had to get to like, what's your one word? You got your mission statement or whatever. What's your one word? It's hope. And so we're like, okay, this can be a dark field. So we want to project light into that space and say there is hope. People do recover. There are positive things coming out of this movement that we all can grow and learn and whatever. And so you'll see that, in the messaging, that we're not denying the pain and the struggle. We spend a lot of time in that space, but encouraging people to find their path and their journey into wholeness and health and light is kind of, thematically what we're trying to do.
And you do a great job with it. And one thing I love about the APC as well, is that there is space for everyone. Like, you can be an ally and be in the APC.
Yes.
You can be a recovering person
Yes.
and find a place. You can be somebody who is in the middle of a substance use disorder and find hope in life.
Our families that have
Our
lost.
families.
Lost people.
Yeah. What are your thoughts on, because the name addiction prevention, right, says one thing, and then we're talking about back in recovery, right?
Yep.
And just truthfully, from my own story, I'm just more involved on the back end when things have fallen apart,
Yes.
right?
And
by personality, that's a little more exciting for me, as you said earlier. To watch people actually recover is a big deal, right?
Yes.
So what's the intersection of prevention and recovery? What do you see on some? Because I think they go hand in hand, obviously. Yeah.
I think they go hand in hand. I always, when I describe APC, I kind of talk about two prongs of their work, that they care about this issue very deeply, so they want to work on prevention when they can. Why wouldn't we? Especially when you've been working with recovery folks and you've kind of learned some of what goes into, or the vulnerabilities to, substance use disorders. You can put that learning in detail into the prevention piece.
Yeah.
And then I tell people, the other part is resources and education and lighting up the room for those who are approaching or in recovery.
Yeah.
So I think it goes hand in hand beautifully, really. Yeah. And I mean, some people, I suppose, might think, if you're focusing on prevention, that, maybe you should focus more on the other. But again, I think
recovery
both at
is
the
prevention.
same time. Yes.
Yeah, I think good recovery is always prevention, and I think good prevention then informs recovery as well.
Well, and I think, when we're out doing, have the opportunity to do prevention education with adults, in workplaces. I mean, parents is one of our target groups, for prevention, and it's, parents are busy. And if they're parents of young children, they're not thinking about substance use yet.
Yep.
So then we kind of said, we got to get creative. We've got to do these prevention presentations in places where the parents are. But they don't know they're coming for that. So workplaces, but it is still one of our favorite places. But when we go in to do prevention education, one of the first things we talk about from the very beginning to normalize it is to start off with, hey, we all have a relationship with substances. I have a relationship with coffee. I have a relationship with sugar, that I don't want to have. But we never want the substance to gain the power. Okay? So once you start talking in that language, and even when people begin to misuse medications or something in that space, that's a relationship, and so, gauging the terminology around, I've even heard it just recently. I was in a meeting where they were saying, we're working with people to adjust their relationships to their substances. And I was like, okay, there it is again, but the point is that, less than 10% of the people actually reach out to get help around substance use before a crash. And so that
absolutely,
any education that we can do in that prevention space, not only prevention at every age for parents and students, which we're very passionate about, but even just starting the conversation of, hey, this can happen, and it does happen to normal everyday people with an injury or a surgery, and there's opioids involved, or with a glass of wine at night that turns into two, and every night it happens gradually. You don't even realize it's happening. But until you have that conversation in a room where everybody is sitting there, and it's not just a few, these are the strugglers, and then there's everybody, all the normal people, we're doing ourselves a disservice by not having those honest conversations and encouraging people, hey, if you're thinking about a medication that you're thinking about more than you want to be, have that conversation with your doctor. There is no shame in that. That is not a moral failing. That is a part of psychology and physiology of being human,
And you asked about the intersection of prevention and recovery. And what I always tell folks about both of those is there's nothing we're going to be recommending that we wouldn't also recommend just for good general spiritual, emotional, and physical health.
Yes.
These are good things for you as a human. We want you to thrive. Prevention is about helping somebody address the vulnerabilities and thriving. Recovery is about helping people build this life they want to live and enjoy. And so I think both of those are really promoting, being a human and enjoying it and being healthy.
Yeah.
Yeah.
So you mentioned earlier you really enjoyed group therapy.
It. Yes.
Can you talk a little, because we'll talk about your transition in just a minute.
Sure.
But what was it about group work that you liked? Yeah.
Group is special. There is nothing like group. I do individual therapy now. I've done individual therapy, but walking into a group, the synergy there is amazing. And especially for recovering from substance use disorders, I believe it happens in community. Mm-hmm. I believe the power of connecting to other people decreases shame, increases, if we want to talk about just like brain chemistry, it helps our nervous systems calm down. It helps us access other neurotransmitters when after addiction, dopamine's a little depleted, but we can access that oxytocin, which is our social community neurotransmitter that helps us calm down. We can learn from each other and faster than we could just on our own or in self-study. As a practitioner, you have to be on your toes. Yeah. So it is, when I go into a group, I really take a moment beforehand. I set everything else aside, do a little deep breathing, and then when I'm in that room, I'm in that moment.
Yeah.
And there's nothing as exciting as that, and having to handle things in the moment and be totally present to try to navigate 8 different people and their experiences at once to a positive resolution.
Yes.
I would be tired at the end.
Yes.
I would always need to debrief, but I would always be excited too. So group is the best way to treat substance use disorders. You need all the adjunctive things as well, but it creates some of the best healing. Yeah. So I loved it. And it's just dynamic. It's exciting. Yeah. We talked about seeing people return to even better function, living their lives in recovery. In group, the aspect I loved was people interacting with each other and creating healing. So as a practitioner, if I'm doing my job well, I'm stepping out a lot. Yeah. And other people are creating the healing between themselves.
That's great.
So that's a beautiful thing to watch.
Yeah, yeah. So after decades within the UAB system, you've stepped out of that. Talk a little bit about that and your decision, and then what you're moving toward or to.
Yeah. I don't know if this is okay to say on the podcast, but here we go. I had the opportunity to retire from the Alabama teachers retirement system, and I couldn't pass it up.
Yes.
So it wasn't that I didn't love what I was doing.
Yeah.
I just wanted to take this opportunity from a practical standpoint. And now I took a few months off, and now I'm back at UAB. But my role is very different. I'm part-time, and I do individual therapy, which I love as well. And I see a variety of folks. Everybody who I work with knows my background. So they send me folks I work with folks in recovery. I work with folks who are in the middle of a substance use disorder and wanting help with that. I work with folks who don't want to quit yet. We do motivational interviewing, harm reduction. There's no judgment. But part of working in the field that I did for so many years was learning about witnessing and helping people begin the healing journey from trauma. Mm-hmm. And I found that to be, in addition to substance use, one of my passions. So I get to do that in my current role as well, do trauma recovery, which sometimes involves people using or having used substances, sometimes doesn't.
Right.
And so I get a little more diversity in terms of that work.
And then adjunct with the social work. Are you teaching?
Yeah, I'm not this semester, but
Okay.
I have, and I've taught addiction recovery classes, basic mental health interventions, and then I did one class, which was through a grant that UAB got, the OWEP grant, which is the Opiate Workforce Expansion Program. And so that was a wonderful opportunity to teach. It was both social workers but also nurse practitioners that were in the class. So the grant funded students in social work degrees or nurse practitioner degrees who committed to work in the substance use field.
Do you see that as a growing trend in higher education to do more toward either degree tracks or just educating more of upcoming people that are interested, whatever it is, whether nurse practitioner, going into the social work field or whatever, to actually educate and move forward in the idea of addiction recovery?
Yes, yes, and yes. And that's a beautiful trend where we see some of the stigma decreasing because they have to.
Yeah.
You know, we got to accept reality.
Yeah.
This is happening.
Yeah.
We want to give people quality care. And for decades, the education was nil, maybe a sentence, or maybe...
It kind of came in on the end when there was a crisis or something.
Well, I mean,
here's how to detox somebody from alcohol. So, no, we've got to do much better than that.
A much
and
more
I do
holistic
see that.
approach.
Yes.
I see it in the academic setting.
That's great.
Yeah.
That's good.
And I heard from working with Dr. Eaton, and she was talking about the lack of primary education about substance use disorder on any medical tract. It's just void and needing to make a change there. So that's great.
She's one of my heroes. She's amazing.
I love her.
Yeah.
So can you I know you're not there anymore, but for our listeners, can you educate us about UAB Addiction Recovery?
Absolutely.
And what the services are offered, and if somebody needs help, how they might connect with them?
Absolutely. So UAB has a lot of addiction recovery services. They have a service, Beacon Recovery, that helps those who don't have insurance or the means to pay. The service I worked for is housed in the Center for Psychiatric Medicine, and we had several pillars to what we did as well. One pillar is medical detox. One is outpatient treatment for adults with substance use disorders, and that's the program people probably identify me with the most. It involves group therapy as the main modality, but also individual therapy, family therapy, follow-up group therapy that you get to do included for 2 years, psychoeducation. We have a component to what we do, which is our consult team, meaning a team of doctors, nurses, social workers, and peer support specialists.
Right.
People with lived experience in recovery who go to the bedside of patients at UAB, could be there for anything from a car wreck to a heart surgery, but who have identified there could be a substance use disorder playing a role.
Yep.
They do a beautiful job. And then the other part that we do that maybe a lot of people don't know about is we do evaluations for healthcare professionals to look at, is there substance use disorder? And if so, what are the recommendations? And that is with the different medical boards around the state. So, it's not a well-known program because
Right.
we don't, it's a nonprofit. So, we don't have the advertising dollars, but the number to reach a counselor and talk and start the process is 205-975-8524. The good thing is it's a great number to call for parents, for families. There's no pressure. You can just start to have a conversation. This is going on. Can you help me with what's going on? We have a family support group. I know there are many around town. Ours is just one. And we've had families who start their process before their family member does.
Yep.
They come to a family support group. Their family member's not ready.
Yeah, that happens a lot.
Important.
Yep.
One other thing, if you could touch on just a moment, because I think, as a person in recovery, but also as a parent that has gone through it, and because we do family support groups as well, often what we're facing is someone with an adolescent. And it seems to be a really tough space. Can you comment on that? Any improvement, any place you would, if somebody was listening that was in that situation, anything you would want to say to encourage them? Or
Well, I'd want to offer them a lot of support and a lot of validation that it can be difficult to find resources.
Yep.
Many of the resources that even existed a decade ago in Alabama are gone.
Yep.
So the resources are depleting, but the need is not
It's
depleting.
growing,
It's
yes.
growing, right.
Yes.
So, I would just really offer my support, encouragement. There are some resources, and there are some private resources outside the state. The problem is that they're costly.
Yep.
Beacon Recovery has an adolescent program, outpatient program.
Yep.
That is, finances are not a barrier, but they take all adolescents. So it's a diversity from different socioeconomic groups.
So if I'm that family or parent, and I've got a 17-year-old, and there's a significant struggle here, and I'm looking, what would you say to them right now in Birmingham?
I would say start with Beacon Recovery.
Okay.
Because even if they can't take that person, they'll help you get the resources that you may need.
They know about other resources. Yeah. Okay, so also in your practice now, do you have availability? Do you want to say something about if somebody wants to reach out to you as a therapist?
Sure, I have availability. UAB is a thriving practice.
Yep.
So we see a lot of folks. We are very, very full. The good thing is we are growing our practice to try to meet the need.
Awesome.
So there was, for the past 4 years at the Sparks Clinic, there's psychologists, psychiatrists, but they had one social worker just dedicated to therapy. I make the third. We're adding a fourth in August, and they're looking for another one.
Oh,
so we
wow.
are trying to
Meet the needs.
increase the resources to meet the need. But yeah, they can call the Access Department at UAB, 934-7008. We have a screening process, which is beautiful. You get matched with a PhD psychologist to do an intake to decide which of our 20 providers you would be a good fit with, and to sort of assess, if that person is, should they be doing individual therapy? Do they need a little bit more intensive? Sometimes somebody might need might need more intensive psychiatric care, and the psychologists are really good at figuring them that out and then placing them where they need to go.
Love that.
Yeah.
We always like to end with giving folks an opportunity to talk directly to the people listening. So if there's somebody out there that is struggling and has, for whatever reason, not found their healing, their recovery, their sobriety, what would you say to them?
Well, I love your word of hope. I hope that people will hang on to hope. There are resources. I have to acknowledge that sometimes it's hard to find them.
Yep.
But to keep going, keep trying. And oftentimes people see a lapse is a failure, and it's just part of the journey.
Yeah.
So to keep hope, as long as you're still here, take that next step, and
Yep.
that there are people and places out there to support you.
Yep. Well, thank you so much for joining us today.
you.
Thank you for your partnership. Thank you. Wanna take a drink? Oh,
I made it almost to the end.
You did.
Great, yeah.
Got water here too.
Yeah,
Yeah.
He can fix this.
I think just I can do
Okay.
the last bit.
hang on. I'll give you a minute.
Yeah,
Okay.
We're good.
Yeah. Good. Thank you for, you've been, when we take in social work interns, you've been a mentor to them, and that's been a beautiful process to watch, and I appreciate how much you pour in to those, and, we've hired one of those, so thank you for that. But most of all, thank you for your passion and your work over the years and continued work for those that are looking for, their path to healing and to hope. You've made an impression on the Birmingham community, so I hope you hear that and receive that. I mean, your efforts have really been noted and received, and so many lives have been changed. So thank you so much.
Thank you, Carrie. I really appreciate that. If I even have a small impact, I'm humbled to hear that and be a part of it. And the same for the two of you. You're a known name. Your compassion and your hard work really stands out in this community. So
Thank you.
I've enjoyed the friendship.
Yeah,
and the
same
partnership
here.
over
Yes.
the years. Yeah.
Yes.
Folks, thanks for joining us this time on APC Recovery Cafe, and we hope to see you again next time.
One of the things that APC is known for is being a connector, because we're stronger together.
Not only are we there for those who are suffering through substance use disorder, but we're there for family members, and we really take our job seriously.
We all have personal reason why we're in this field. We're changing people's lives one community at a time.